A very good afternoon to all of you. It is our honor that we have a very distinguished medical educationist, Professor Hossam Hamdy, who would be here to deliver a talk on medical education. I would request our director, Honorable Director, Professor Srinivas, to invite Professor Hamdy to deliver the talk.
Thank you. What a great day, in the medical education of the country, I guess, because the photographs will be in our archives when we have a medical education department in our institution, sir. I have the honor of introducing and give a brief introduction about Professor Hossam Hamdy. Hamdy is a professor of surgery. He writes surgery, but I say pediatric surgery. I'm very proud to say that he's a pediatric surgeon and a medical educationist. A medical educator, a pediatric surgeon, scholar, professional, and leader in higher education in the Middle East and internationally. He has established and contributed to various universities, medical colleges like Suez Canal University in Egypt, Arabian Gulf University, Bahrain, University of Sharjah, Gulf Medical University in UAE. He has served in different senior academic and administrative positions as a former Chancellor of Gulf Medical University, Vice Chancellor of Medical and Health Sciences College, University of Sharjah, Director of the Institute of Leadership in Higher Education at University of Sharjah, Advisor to the President of Medical Education, Qatar University, Dean of Medical College, Medical University, Medicine, Arabian Gulf Medical University, Bahrain. Is a member of the Medical Committee of the Supreme Council of Universities in Egypt. He has served as a WHO temporary advisor as a consultant in medical education. He's an active in medical education, research, and published. The list is very big, and then I will just add up that he's on the editorial board and journals of medical education, medical teacher, medical educator, Korean Medical Journal of Medical Education, member of the World Federation of Medical Education, WFME assessor team. And then he has these many things to his crown, the Sheikh Khalifa Award for Higher Education for Distinguished Professor in Teaching, and also the Knight of the Order of the Academic Palms from the Republic of France. And it's an honor for me to have you, sir. And today we are going to hear from him the present and the future of health professions of medical education from informative to transformative nature. And we are very honored to hear you, sir. In fact, we were having just discussion with him in the committee room. Then he says that he is going to get the vice president, the president, and the crown prince of the country, and then we are looking at how we can establish a collaboration with a focus on medical education between the institutions, the Gulf institutions and the All Indian Medical Sciences. We just had a glimpse of what the AIIMS is doing and how AIIMS is connected to the various universities of the world, and he was very appreciating. And then he said that it is a opportunity for them also, because he was very impressed by two things, our set facility, our the skill labs, and also the focus which we have from the Government of India for the Center of Excellence in Artificial Intelligence and Machine Learning. With this, I once again welcome you, sir, to India, to All India's Medical Sciences, and to the future Department of Medical Education in our country. Thank you, sir.
I request our Dean, Professor K.K. Verma, to honor the speaker with an institute plaque.
Thank you very much. Now I request our director, sir, to kindly present a plaque to Professor Hamdy. So thank you very much. May I now request Professor Hamdy to kindly deliver his talk and enlighten us with his from informative to transformative medical education. Please, sir. Yes.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning. It's a great honor for me and a pleasure to be here in the Mecca of medical education and healthcare in India, and maybe one of the leader in the world. All India Institute, I know about it for now more than 25 years through your ambassadors who have been working with me, like Professor Kameshwar Prasad and other very senior colleagues. Professor Srinivas, the director, we share a lot of things. First, we are pediatric surgeons, and I don't know why pediatric surgeons are also good educators and good leaders, maybe. And I really thank you and thank all India Institute. Thank you, Professor Srinivas, for this kind invitation. I would like to thank Professor Kalapana and for all what you did. I gave her a headache over the last few days, but I really appreciate all the arrangement and the last minute arrangements. She managed to do it and arrange it. I am very glad and happy that you can see these young faces here of the students of Dubai Medical University, one of the leading, maybe the oldest medical school in UAE for more than almost close to 30 years, which when it was established by the late Sheikh Saeed Luta, may God bless his soul, and the foundation. So we are here also to establish this relation, and I thank you. They were very keen to come here and to see this wonderful place and the artificial intelligence and what is happening at the front line of advances in education and research. What I would like to share with you, and please bear with me, I'm not going to bring new ideas, but I want to show you what is actually happening now and what perhaps is happening in the coming few years. The disruption in medical education is huge. I was asked by Ron Harden, one of the well-known medical educators and the chief editor of Medical Teacher Journal, in 2018 to write, we were 5, to write an article about the future of medical education. And you can access this in Medical Teacher. But what I wrote in 2018, some of it still exists, but many things we were not seeing what is happening in these 5 years. And we don't know how it's going to be the work environment when the young students here are going to graduate and work. They are going to work in a different work, which we don't know exactly how it will look like within the coming few years. The disruption is fast, and we have to respond to that. So in my presentation, I would like to give more of a bird's eye view of these changes and of the ecosystem of health professional education and what's happening all over the world, not only in UAE, but UAE is moving forward in this direction in many aspects. I think, yeah. So I I always start saying that medicine is a social science. So even with the technology, but medicine is a social science. It's about the people, about the society, the human interaction, the listening to and learning from the gurus who are the faculty and so on. And all this is embedded in this rapidly changing healthcare system. And the ecosystem, it's important to see all the systems which affect medical education and healthcare. We are surrounded by different systems. And sometimes the problem that these systems, they don't talk to each other, or we don't visualize this system, but they are influencing everything. And I'm going to talk about system thinking a little bit during my presentation. And I believe that the community expectation and needs drive the healthcare system, which drive the health profession education systems, which will produce the health professionals needed for the country and to respond to the healthcare. So healthcare drives education. It's not the opposite. And the disruptive forces, which you all are aware of it, which are changing healthcare system. Now all these advances in medical knowledge, sciences and practices, now genetics and molecular medicine and precision medicine, and the vocabulary and language is different from what I have learned. Now they are very much detailed than what it was before. But it's also in application. When treatment of cancer breast, they look into, it's not only the receptors which used in the past, estrogen and progesterone receptors and some of the markers, but now it's becoming very sophisticated precision medicine. The technology for diagnosis and treatment and communication, the demographic changes which are taking place, the environment and sustainability, environmental problem becoming now one of the main health problems all over the world, environment, wars, what is happening, and so on. Of course, patients are better educated, the informatics and big data analytics and AI are becoming very important, are embedded in education and in healthcare. And AIIMS here is leading, and the director has put it very clearly in the vision of AIIMS that this is an area of excellence which AIIMS will move forward through research and through application of all this new technology. Global health is very important. What happened in China, what happens in America affects the whole world. So there is this domino effect, because again, it's about the systems. So the current problem of the current system of healthcare is that is fragmented sometimes, and the systems and this leads to poor patient and community satisfaction, low quality, high cost, low value. And it's based on single providers. So the doctor treats the patient, the nurse is interacting with the physiotherapist, the pharmacist, everyone they are separate. We talk that they should work together, but actually, and they are learning separately. And now we are moving into this model, the value-based healthcare, from a disease model to the wellness models. And in a short presentation of AIIMS, I have seen what they're doing and their engagement with the community and with the poor and the needy and so on and so forth. It's much more than only tertiary or care. And value is quality divided by cost. So cost, the finance of healthcare is very important. And now we are teaching the medical students. They have to learn about this. They have to learn about the system, money, how to spend and where to spend, where to put the priorities. These are becoming part of the curriculum. So the new healthcare system, the delivery of care beyond the walls of the hospitals, now the more ambulatory care, more community-based healthcare, even home care in Dubai, in the primary healthcare center, the doctor can communicate with the patient and they can receive the treatment while they're still at home. No need to go to the health center or no need to go to the hospital. It will vary, but at least Dubai healthcare is moving in this direction very fast. So this is the current traditional health professional education environment, that the medical students, they learn from patients. The pharmacy students learn separately from patient, or they have interacting with the nursing. And the same in the healthcare system. There's individual, limited collaborative practice in healthcare systems. And then came the issue of IPE, interprofessional education. It's one of the area which everybody is talking about it. But practically, it's not very well implemented, because IPE, it lacks something. It's not interprofessional education. It's interprofessional education and collaborative practice. It has to be practiced in the healthcare system so that the students can see it in practice, not just imagining how it will work. And you can find that we have been talking about what I call it learning together for working together. So it has to start early. These students, your students, our students, they have to see it in practice in the hospital, how the physician, the nurse, the pharmacist, how the doctor goes to the pharmacy and take his opinion, what I should do, which dose I have to give it to this. We don't know all this, but how they will do this. So this is one of the important direction all over the world which is taking place, interprofessional education and practice, collaborative practice. The problem also there is a big problem in where to train the future health professional. There is increased demand for competent health workforce all over the world, but there is shortage of training facilities. Maybe here it's different, but I think still. And the limited government support in turning the places and providing the support. In many places, the private sector constitute around 60 to 70% of the healthcare system in providing patients. So, and we are ignoring this sometimes, and that's why the WHO, they have came up with the importance of the public-private partnership and how to change the private sector, private hospital, private healthcare to become at the same time an academic health center. So the problem which exists now about what this complex relation of medical education and healthcare system, the management people, they talk about what's called the wicked problem. I learned this from the management. And the wicked problem is a problem which doesn't have a solution. It keep evolving but health professional education is in the center, is in the middle between two culture, the educational culture or educational organization and the healthcare. And we have to correspond and interact with these two cultures, the healthcare and the educational. We are in the middle. We are unique, different from engineering and so on. Now, this has led people think that competency-based education, which came, and I know here in India, you have started this competency-based education about maybe 5, 6, 7, 10 years ago. But actually, I started competency-based education in 1979. And my dear friend, Professor Prasad, he was been with me after that. And we were implementing competency-based education for more than 30 years. So there is a shift now from course-based education, what the graduate knows, to the competency-based education of the graduate is what he's able to do. This is competence, ability to do something. But now we are also moving towards trust-based. Can I trust this graduate to treat me or my child, or at that level with the complexity of the problem of the patient? So this shift is taking place, but nothing is new. And the word fitness for purpose, people ask me about what what do you mean by quality in medical education? And by the way, I have a PhD in education, which was based on how to measure quality, which I don't know exactly how to do it, but I can feel it. When I come and enter this place, AIIMS here, and talk and interact and in brief, I can feel it, I can smell it, I can see quality. It's a sense which is developed when you come to an institution. Translated into numbers, it's okay, KPIs and things, but it's much more than that. But the simple definition of quality is fitness for purpose. It's very simple, but fitness for purpose. So what is the purpose? The mission, vision, the role of the leaders here, they are translators of meanings. How to translate the mission and vision and each word into a strategic direction and implement it and keep revising it. So, but the problem, competency-based education has many problems. And the competencies are poorly described. We're not talking about a subject or an objective in a course as a competency. Competency is much more than that, but the poor description of that. And competency overlap. So if you have an excellent biryani and you eat it and you said to your wife or whoever is cooking, it's fantastic, it's very tasty. So what score you will give? Well, I don't know, maybe 9 out of 10. No, this, I don't want this. Give me a score for the rice, for the tomato, for the chicken or for the fish. And then we'll add these scores together. And then Professor Prasad will come and say, oh, wait, you cannot add them together because these are not numbers, the 1 to 5 Likert scale and so on. These are categories. And so we are in this mess of trying to have everything, call it objective, while everything is life is subjective. Even the MCQs is subjective. And I can explain that. So the competency overlap and in its totality. And the challenge is how to translate, implement, and assess these competencies. So these are very important things we have to think about. I have modified this conceptual model of the Dreyfus and Dreyfus model. And it's a fantastic model. It's not from medical education. It's again from management. And that, but you can apply a concept as one of the conceptual models that the students or the learner at any postgraduate, undergraduate, they come into the system as novice, and then they move to another level, another phase to advanced beginner, competent, and then you can have them maybe after graduation, another level of competence, and then it goes into the finishing the postgraduate, working and so on, they become professional and experts. So you can find that you can develop your program using this as one of the models, and then you can put assessment at the different phases, how to assess in the different phases, and your expectations on the proficiency-based, I call it professionally-based progression. And then when you come to the competency framework, and I know you have in India here a competency framework, but they are all similar. So if you look at the ChemMed in Canada, or the ECGME of US, or GMC of UK, they're saying the same thing about knowledge, patient care, system-based, interpersonal communication skills, and so on and so forth. Even in our part of the world, in Saudi Arabia, in Emirates, in Egypt, it's exactly the same. So, and I'm sure next time I will have the competency framework of India, which I'm sure I will add it here, but it will be always the same, similar to this. So now we are translating these competencies to EPAs. And again, EPAs is a concept which is not very new. When Tenkate from the Netherlands, he came and he spread the word EPAs. We have developed this many years ago. We call it something different. We call it optimum physician performance, OPP. What would be an optimum? What do you expect from the graduate as when he starts working as an optimum performance? But you find that these EPAs concentrate more on tasks, what he would be doing. And there are about 13. You can add more, you can reduce, but there are many things related to that. But one of the things which about the system and system failure, it's one of the issues, one of the EPAs, and the others. Now, all this is translated into a program, into a curriculum, and curriculum is coming, actually, the word is coming from Latin, cursus, or in French, courir, mean running, to run. So it means an element of changing, that the curriculum is keep changing and keep evolving. And the curriculum is composed of multiple systems. You have the outcomes, you have the content, you have the culture of the students, you have the technology, assessment, accreditation culture, organization culture, so on and so forth. So all these elements are systems, and we have to be alert and aware, because this system will guide what we are doing. So I came up with this multi-systems of the curriculum, and again, it's another, which curriculum are we talking about? Is the curriculum which is on paper, the intended curriculum, what is declared curriculum? That's one type. And then when it is implemented is what I call it the curriculum in action. And then the students learn in a different way. They have their own curriculum which they develop it, guided mainly by the assessment, what will come in the exam. And then they have their own culture and environment, that's the hidden curriculum. And then there is the assessed curriculum. And then I came up, okay, after all this, how much of this is actually used after graduation? And that's used curriculum. So we have to look at all these systems of curricula. And that's why system thinking is very important, because we always see what's above the water of if you consider the iceberg approach or thinking, but below the word, the less visible and the not visible, all this affects the education, affects the curriculum, affect the implementation, affect the students. So we have to be conscious and aware and think about the invisible or less visible ones. Now, if you apply this, again, system thinking, curriculum design, the traditional model, which more than 100 years, where you have 2 phases of, you call it pre-clerkship, pre-posting, whatever the term, basic science, basic medical science, and I know that here there is applied medical sciences, and then you have the clinical sciences. So this, it's more based on departments and silos, and no real integration, maybe to some extent. And then we came many years ago and developed the one on the left side here, integration. The word integration came up, integration. But we forget why integration. What's wrong with having courses? And the whole integration is because to see the relevance of what is given and to link it to the practice as much as possible. But culturally, the tribes of the basic medical scientists and the tribes of the clinical science, they don't communicate very well. And that's why it's a solid wall and which existed. Although on paper there are modules, there is whatever system you are using it, but to penetrate this wall is difficult. So many years ago, we came into what I call it the fusional model, to try to break this wall. And the fusion model is based off concept which I introduced, is teaching basic medical sciences in the clinical environment. So the anatomy, for example, in the anatomy, I will have ultrasound machine in the anatomy place, because the students and the faculty of anatomy use ultrasound. The biochemistry is taught, and the physiology is taught on a ventilator, the physiology of the lung, for example, and the anesthesia machine. They can learn everything if they understand this, and so on. In the imaging, you will find all the MRIs, the CTs, and because that's a purpose related to teaching anatomy. So things are changing even in public health. It is not only the people of public health or the faculty who teach, but everybody, the public health dimension you call it community medicine, you call it public health, you call it whatever. Now they're coming back to the word public health again, and there is a new chapter I wrote it about public health, although I'm not a public health person. So one of the new types of curriculum which I have implemented is this 5 pillars model, where you have the basic medical science and applied sciences, you have the clinical sciences, these are the pillars, but you have another pillar of the population and health system science. Health system science is becoming very important. And then research and innovation, it has to be one of the verticals. The technology and data science, all this has to be vertical in the curriculum and continuous in a spiral fashion. Ethics and professionalism cuts across all this and is embedded in all this. So that's again another model which we have implemented. Now, the problem is that you have now the knowledge, new knowledge, which were not in my time, and even maybe Professor Sinavas, he knows better than me in this knowledge domains, but I'm learning, and many of you are learning about this. And but then the challenge comes: how the students will learn all this together. It becomes huge, and there is a tension between no, it's important to cover everything and mastering things. So is it better to cover or to master? And there is a disease, I don't know if you know about it, the pathologist, he is called coveritis. Have you heard about coveritis? Maybe not. But Abrahamson, many years in the 50s, he talked about diseases of the curriculum. And one of them is coveritis, that you want, it's a disease, you want to cover everything, like curriculum hypertrophy and curriculitis. So all these are diseases of the curriculum. And now we have new students. I'm not sure, maybe I am in the boomers level. There is a faculty in Generation X around that. And then Generation Y, maybe some young faculty, and then the students, the current students, my students here, I think you are somewhere under Generation Z. And we don't know how they learn. And there is a research, which I hope I can do it with you here, and we are doing it. We don't know how students learn in 2025 and beyond. It's different from the way we have been learning. And of course, for the senior people here, your grandchildren or children, they are using buttons to click on buttons. They came up with that. So how you are going to teach them later on? So the current students, they're learning, they have access to information, AI, and new learning approaches. No longer attend preclinical classes in person. I've checked this. If you remove compulsory attendance, so it's funny. Now the students are looking. They want the guru. They come to the classroom to learn from the guru, from his experience, from storytelling, from guiding and supporting and facilitating the learning, because the knowledge, the lecture, they can get it easily from YouTube, from asking ChatGPT or Gemini or whatever, and it will produce for them. So now we are in a moment of what I call it co-development or co-sharing. The faculty with the students, they develop the learning content and material together. And the time spent with the faculty will be more in facilitating and learn from them, from their wisdom. Students looking for the best lecture, as I said, from online or web-based. And I think they are very fast. They don't waste time. They run it, what do you call it, Yeah, so even they want, and they are in the gym and learning, and so on. So, and at convenience. I was just recently in one of the schools here, and the library is full of books. And I thought, why you need these books? And the time of the library from 8 till 8 in the evening or 9, something like that. So I said, no. The time of the library is, it's open 24 hours, 7 days a week, because each student is carrying the whole library in their pocket. You know, they have their mobile. They have access to the library, and it becomes more like a Starbucks. It's a lively, enjoyable environment. So they learn in small groups. They like to work in small group. And they don't read textbooks or journals. Please correct me if I'm wrong. In my time, we used to have the books, big books. Now, on your iPad, yeah. But a chapter or part of it. Anyways, they like to review exam questions, and preparing for exam. What is becoming important is collecting evidence of competence. That's why e-portfolio at all levels is important. Because this will show, and if you can align it with the competency framework, so by doing an e-portfolio, they would be able to demonstrate that this is what we have learned and this is what we can do or able to do. So, so the relation to the competency framework and the themes, knowledge and skills would be presented as modules and bricks, small bricks of learning. And the role of the students and faculty is how to join these bricks together. That's integration. I call it the Lego approach, co-creation. AI system will be used in developed learning resources. Students and faculty will be using access to ebooks, and assessment would be integral to this new structure. This is an example of the new classroom. So please, if you are going to build new classrooms, don't have these rows but it will be something similar to that, very enjoyable. And this is not, it cannot be done. No, actually we did it. And it's cheaper even sometimes than doing, but it's a nice environment. So that's one of the, you can see they work in small groups, the interaction, the faculty in the middle, and so on. You can have 100, 150 students even in one place. These changes will have an impact on the new ecosystem of health professional education, from the physical facilities which will be needed, from the faculty new role. The faculty new roles, they will have a new role. And I am very happy that here in India, you are not using the credit hour system. Maybe because you have dictated the number of faculty needed for the number of students which you have, and they keep counting. Because the credit hour system is a crazy system developed by the American in 19th century. It still is governing the world till now. But everything will change. From the legislation and regulation, from the economy and finance, the governance, leadership and management, accreditation and quality assurance will change because the students' learning is changing. So this would be the new faculty, from information giver to facilitator of learning, role model, guru. I like the word, the name of guru. There will be perhaps a faculty track system. Those who are, and there is a concept of 80-20. 80% could be research, 20% education, or clinical 80% and 20 education and research. It's just distribution because you cannot be excellent in everything. Thematic organization of the faculty, and the role will be from a teaching, what is called sometimes a teaching load, it has to move to become more of educational load, which is beyond giving the lecture all the time related to that. The new technology, of course, AI, machine learning, robotics, and data analytics, and so on, will have, it's a major paradigm shift. Recently, I was part of a group, we have published in JAMA this article, which I try to have a look at it, because this is the first competency framework in digital health competency in medical education. And this can guide this framework can guide the development, the vertical development of technology, digital competency, and AI. The students, they have to learn because they will be working in an environment rich and enabled by AI, not replaced by the clinician, but they will be enabled by this. So they have to learn this. This is using an AI and simulation, which I developed. I don't know the voice, but it's, anyways, it's a simulation, but AI will respond to the symptoms the patient is presenting it, and they select and so on. Maybe another time I can go in details about that. The assessment system will change. So more of the workplace-based assessment, capturing longitudinal students and patient experiences, evidence of competency acquisition, readiness for practice, and interestability. All this are becoming part of a new assessment system, and even using OpenAI in examination, which we did. This is an exam which I developed it in 2017 to integrate the different competencies. So the students will perhaps see a simulated patient or a real patient. Family will be there to explain what's the problem, interacting with the patient. Nurse will be there, how he interacts with the nurse, how he requests, for example, a approval from insurance company, how he manages the hospital management or the electronic medical record, and all these competencies which we don't train them usually on how to use it, and we don't assess it. And as I say, it has to be assessed in its totality together during the encounter. Now, the accreditation system also will change, because it was a system which was based on counting numbers of hours in a lecture hall, and then coming up with other numbers, but you cannot count self-directed learning and how to do that. So this system of the credit hour system, we need to revisit the metrics of measurement when it comes to quality assurance. So I am advocating more the Kirkpatrick model, which evaluate more outcomes and impact and results, rather than focusing more on inputs and processes. Yes, you should have a little bit of looking at it, but what the graduate will be able to do, what the impact, all these KPIs which you develop them, this will be the focus. And in UAE recently in January 25, they have changed the accreditation system to have more weight toward the results and level 3 and 4 of something similar to the Kirkpatrick model. So, moving from a time-based education to a trust-based education. So, this is perhaps my last slide, is that we have to be aware of the different systems, the patient system, the provider system, the student system, the healthcare system, the educational systems. And the students come as a novice, and he is interacting with all these systems, and we have to guide him how to benefit and how to approve, how to benefit from interacting and see the invisible part, and not to look at things in isolation. So my personal view, we are preparing students who will work in a world we don't know exactly how it will be. We have to be very sensitive to the fast changes in practice and education systems. Think holistically, system thinking, while planning and implementing. Thank you very much.
Thank you very much, Professor Hamdi, for a very, very lucid and wonderful presentation and your insightful perspective on the present and future of health professions education towards reforming the educator as a facilitator on the current, evolving, and unprecedented changes in educational and informational technology in the healthcare domain, and how well you illustrated that how the students need to holistically learn, interact with the healthcare system and the various other domains in order to have holistic learning, and what are the ways we can measure this kind of learning. So the only change in constant, and so it is true for medical education also. So we need to constantly evolve, and we are inspired that even at this stage, being such an eminent medical educationist, you are still undertaking research to see what are the ways that the students are learning. So it's very motivating for us who are attempting towards contributing to medical education and technology. Thank you, sir. So I wish to thank our distinguished the Director, AIIMS, Professor Srinivas, Dr. Dean, Professor K.K. Verma, Dean Academics, for sparing their valuable time, Professor Kameshwar Prasad, Dr. Nagpal, and all the other distinguished faculty members, faculty of the CMET, of the various basic departments, Department of Pediatric Surgery, our scientists, students, and all the supporting staff from AIIMS, including CMET staff, in organizing this event and talk. And a special thanks to Dr. Kamal for coordinating the entire event, and Director's Office. Thank you all. Before we proceed for lunch, I request you all to go to the convergence stair for a group photograph to capture this moment. And we are honored by our visiting guest, and following which we will have lunch. So now I request Professor Hamdi that if there are a few questions, if you would kindly address those. Yes. Dr. Anu, you have any questions?
Well, you see, the difference between competence and EPAs, competence is an ability to do something. That's why you can do it in a skill lab or with simulated patient, while EPAs is tasked with real patient. Dental education are different from us because they treat patients, and it's easy when they are still students. EPAs, you can, depending on the complexity of the task, but it is possible working toward the EPAs. So there are different level, what they call it, the milestones towards the EPAs. So you can start early, for example, exposing to real patients to take history, for example, or to do some simple procedures related, or so the area of communication. It can be with real patients. So you are building this, but you are increasing the complexity of the situation, the complexity of the patient, till you approach the point of exiting from the curriculum, and then the postgraduate studies. So you can redesign what you are doing and move the students from the skill lab, if you are teaching at the early phases, skill labs, to the work environment and practice. And I'm very happy that here in India and here you have this early clinical exposure program. And another wonderful thing you are doing it is when the students are responsible for 5 families,
Family
the
community,
which is fantastic thing, because they take responsibility of 5 families and they follow them up for several years.
Yes.
Thank you for the lucid talk, sir. A thought-provoking one. You touched about the artificial intelligence, sir, and we have been using in clinical science for various monitoring tools nowadays. How do you take it for the teaching training modalities? Because nowadays, when on rounds I would ask some question, they will go and type on the AI and they will come with the ready-made answer without interpreting the clinical interpretation of it. So how do you look at, and as a teacher, what cautions and precaution we should take off that our students are in the right direction, even if they want to use AI modeling for teaching trainings?
Well, you cannot stop them from using ChatGPT. They become their friend. It's the assistant with them. But I think we will never replace the good clinician. We will never replace that. Every patient is a unique situation, and the disease, we are not treating pathology, but we are treating Mr. Kumar, who is this patient. And any disease is an event, is a unique event in the life of this patient. So they have to feel that. Yes, they can get, they can put, they get the information on how to treat and so on. But they are looking at the clinician to be their a role model. They have to aspire. And that's why having them close to the practitioner, to the clinician, watching him, following him, the old apprenticeship model, which cannot be replaced in this. Access to information, to your lecture, my lecture, on anything, they can have it. But they lack how you talk to the patient, because each patient is different. In my previous university, I used to send the students in year one, day one, to the hospital. And I've asked them to go and go to some units, like for example, the dialysis unit. And they take a chair and they sit next to the patient who is bored on the machine. They're not talking about medicine, but they're talking about, how are you, Mr. Kumar? What you're doing? How this is affecting your life? Who pays for this? And open this and leave the patients to keep talking and talking. The problem in communication skills, that we call it a skill. So it's not communication skill, it's communication with the patient. And the skill, because once we think of communication as a skill, we think as a procedure, how to start, how in the middle, follow a checklist, asking these questions. But even if they just listen, that's a communication. If they just ask few questions, the whole area of empathy and so on. So the clinician, the reasoning, the magician, how you came up with this diagnosis, and you have to be to explain to them how you think and how you analyze the situation. What are the key features in the story of this patient which led you to think and to re-rank the probability? I hope I responded.
You're correct, but on the other side, even the AI modeling nowadays, they are creating a standardized patient. And same thing, even the emotions and feelings are coming up, and few of the platform are available. So you create a scenario that obstructive pattern, obstructive bowel obstruction, and they will behave in the same way with the tones and everything. So I do not know how to balance. You rightly said that something has to have a human touch, but those emotions being generated there, you can just guide us that what future, the educationist should do so that they remains on the balance side. And they're good platform where if I want to teach my patient how to provide an end of life care counseling to a patient, a software AI base is available, and they will just judge your expressions and will try to put it that now you counsel on this aspect. On the other hand, when I teach on my bedside to patient that how I am counseling for the end of life care, I agree that there are two different aspects. On one, I am talking to screen. On other, I am talking to a real patient. So that touch probably is losing, and AI is trying to replace it. I do not know for what reasons AI is coming up. So how to protect it? But how to make our students understand that this is for learning exposure. But as you rightly mentioned, that the human touch, the bedside teaching, the apprenticeship and mentor-mentee relationship needs to exist like this.
Must have this operation. Yes. They want a human being to talk to them and convince them about that. The machine can come up, you have these options, and they can discuss it.
So
So
I'm talking about the student teaching, sir. Patient is okay. When students want to teach, say for example, I want to teach my student how to counsel end of life care to a patient.
they have to observe you doing it,
They are moving towards the screen,
because
sir.
you are better than the machine.
I guess.
So I think the emotional connect cannot be simulated. So the student has to learn from the facilitators. Yeah. Thank you, Dr.
Thank you,
Gad.
sir.
And thank you, Professor Hossam
Can
Hamdy.
I ask the students
Yes,
if they have
yes. So we have enthusiastic students from the Dubai Medical University. If you have any queries.
anything from your experience?
The AI for like history taking. For example, let's say I know I'm not very well learned in the history taking, let's say for GI or for hepatitis, let's say. So I would just like open ChatGPT, like, hey, be a patient with hepatitis. Like these are the age group and whatever. And I'll be the doctor and I just start taking. And sometimes they're really great tool, and sometimes we notice the mistakes that it says because we know like what we studied. So sometimes there are some, it's very helpful sometimes, but other times there's a lot of mistakes.
But still you
AI.
need the patient. Still
Yes,
need-
still, like because I know what's right, it's because I've seen the patient in hospital, so I know that what is said is wrong and what said is right.
Professor Hamdy on the AI.
Yes,
you.
you can.
So thank you all, and I hope the students from DMU have a good time and get the opportunity to visit some places in Delhi and interact with people. And thank you all for being here. And I also see Professor K.K. Deepak, he was mentioning in Bahrain, he was already introduced to Professor Hamdi, and we have our former Dean, Professor Subrata Sinha. So Professor Sandeep Agarwala from pediatric surgery and other faculty. So I think over lunch we can interact more. And before that, we have a group photograph near Convergence. Thank you.
Just one moment. I think I am greatly enamored to be present this morning just by chance. But what gives me a big reminder that I'm a fourth Amsonian, graduated in 1963, having gone around the whole world, but most significantly, I was the Mustashar Wazarat-e-Saha in Abu Dhabi for 10 years, from 1994 to 2004. And I'm reminded what we had achieved was transformation of health sector in the entire United Arab Emirates. And Mustashar Wazarat-e-Saha was, in fact, meaning the principal advisor with the rank of the minister, with the powers of the minister to transform health sector in that country. And the money was not stopped. And ADIA, which is the Abu Dhabi Investment Authority, was on my right hand to develop that factor. Now, having been there, returning back on 2004, what I've seen in the last 20 years is so tremendous that has been accomplished and far beyond what, as an Amsonian, I had the opportunity of contributing. And thank you, Dr. Srinivas, for inviting me here. And just by chance, I happen to be here, and by the grace of Dr. Srinivas, I could participate in this. I would say that great pleasure. I don't want to use Arabic because that's not the word I would like to use in this forum. Shukran.